Question 1. A patient presents with symptomatic bradycardia. What is the initial drug of choice for management? A. Dopamine. B. Epinephrine. C. Atropine. D. Vasopressin. Answer: C. Atropine. This question focuses on the initial pharmacological management of symptomatic bradycardia, which means a slow heart rate causing symptoms like dizziness or low blood pressure. The keyword initial is crucial here, pointing to the first-line medication. Atropine is the drug of choice because it blocks the action of the vagus nerve, which slows the heart, thereby allowing the heart rate to increase. For example, if a patient's heart rate is 40 bpm with associated hypotension, atropine 0.5 mg 4 would be the first medication to administer. Remember, atropine works by speeding up the heart, making it ideal for initially treating slow heart rhythms causing symptoms. Question 2. A patient is in pulseless ventricular tachycardia, private. After the second shock, what is the recommended dose of epinephrine for the next medication administration? A. 0.5 mg 4/IO. B. 1 mg 4/IO. C. 2 mg 4/IO. D. 0.1 mg 4/IO. Answer: B. 1 mg 4/IO. This question assesses knowledge of cardiac arrest pharmacology, specifically the epinephrine dose for pulseless ventricular tachycardia, private, which is a life-threatening arrhythmia. The phrase "after the second shock" indicates that the patient is in an ongoing resuscitation effort. In cardiac arrest algorithms, the standard dose of epinephrine is consistently 1 mg 4/IO, administered every 3 to 5 minutes, regardless of the rhythm or number of shocks given. This consistent dosing helps simplify the resuscitation process, ensuring epinephrine's vasoconstrictive and chronotropic, heart rate increasing, effects are maintained. Always remember the standard 1 mg 4/IO dose for epinephrine in cardiac arrest, delivered every 3 to 5 minutes. Question 3. What is the primary indication for administering adenosine in the ACLS algorithm? A. Asystole. B. Pulseless ventricular tachycardia, private. C. Supraventricular tachycardia, SVT. D. Atrial fibrillation with rapid ventricular response. Answer: C. Supraventricular tachycardia, SVT. This question tests understanding of adenosine's role in the ACLS tachycardia algorithm, specifically its primary use. The key phrase, primary indication, directs you to the most common and effective use. Adenosine is the first-line drug for stable, narrow-complex supraventricular tachycardia, SVT, a type of rapid heart rhythm originating above the ventricles, because it temporarily blocks electrical conduction through the AV node, often terminating the arrhythmia. For example, if a patient presents with a regular, narrow-complex tachycardia at 180 bpm, adenosine is the drug of choice to attempt to convert the rhythm. Always remember that adenosine is the go-to medication for stable SVT, helping to reset the heart's electrical system. Question 4. What is the initial recommended dose of aspirin for a patient experiencing an acute coronary syndrome, ACS? A. 81 mg chewable. B. 162 mg chewable. C. 325 mg chewable. D. 650 mg chewable. Answer: C. 325 mg chewable. This question asks about the initial aspirin dose for acute coronary syndrome, ACS, which includes conditions like heart attack. The keywords initial and acute coronary syndrome are vital, pointing to immediate treatment for suspected heart events. The recommended initial dose of non-enteric-coated chewable aspirin for ACS is 162 mg to 325 mg, with 325 mg being commonly preferred for its rapid antiplatelet effect, helping to prevent further clot formation in the coronary arteries. For instance, if a patient complains of sudden chest pain suggestive of a heart attack, giving them 325 mg of chewable aspirin as soon as possible is a critical first step. Remember, immediate aspirin administration is crucial in ACS to stop the blood clot from growing. Question 5. A patient in refractory ventricular fibrillation, VF, despite shocks and epinephrine has received their first dose of antiarrhythmic. Which medication is typically administered next? A. Lidocaine. B. Procainamide. C. Amiodarone. D. Sotalol. Answer: C. Amiodarone. This question tests knowledge of the cardiac arrest algorithm, specifically the antiarrhythmic medications used for refractory ventricular fibrillation, VF, after initial defibrillation and epinephrine. The phrase refractory ventricular fibrillation implies the rhythm is not responding to standard treatments. Amiodarone is the preferred antiarrhythmic drug for persistent or recurrent VF/pulseless VT, with the initial dose being 300 mg 4/IO. It helps stabilize the heart's electrical activity. If a patient continues in VF after several shocks and epinephrine, administering amiodarone is the next step to try and achieve rhythm conversion. Think of amiodarone as the primary antiarrhythmic agent for stubborn VF/private during resuscitation. Question 6. A patient is experiencing torsades de pointes. Which medication is indicated for treatment? A. Calcium chloride. B. Sodium bicarbonate. C. Magnesium sulfate. D. Atropine. Answer: C. Magnesium sulfate. This question assesses the specific treatment for torsades de pointes, a unique type of polymorphic ventricular tachycardia. The medical term torsades de pointes is the key indicator for the correct drug. Magnesium sulfate is the drug of choice for torsades de pointes, regardless of the patient's magnesium level, because it can stabilize cardiac cell membranes and reduce the risk of the specific arrhythmia. For example, if an ECG shows the characteristic twisting QRS complexes of torsades, a rapid infusion of magnesium sulfate is the immediate intervention. Remember that magnesium is the primary treatment for torsades de pointes, which is a life-threatening rhythm. Question 7. What is the correct initial dose of adenosine for stable supraventricular tachycardia, SVT? A. 3 mg 4 push. B. 6 mg 4 push. C. 9 mg 4 push. D. 12 mg 4 push. Answer: B. 6 mg 4 push. This question specifically asks about the initial dose of adenosine for stable supraventricular tachycardia, SVT. The keywords initial dose and stable SVT are important, as adenosine has a specific rapid sequence administration. The correct initial dose of adenosine is 6 mg given as a rapid 4 push, followed immediately by a 20 ml saline flush. This rapid administration is necessary because adenosine has a very short half-life, usually less than 10 seconds. For instance, if a patient has a stable SVT, giving 6 mg adenosine rapidly is the first step, and if unsuccessful, a second dose may be given. Always remember that adenosine's initial dose is 6 mg and must be pushed quickly followed by a flush. Question 8. In which situation would sodium bicarbonate be indicated in the ACLS algorithm? A. Routine cardiac arrest. B. Hyperkalemia with ECG changes. C. Hypovolemic shock. D. Asystole refractory to epinephrine. Answer B. Hyperkalemia with ECG changes. This question tests knowledge of specific indications for sodium bicarbonate, a drug not routinely used in most cardiac arrest scenarios. The keyword indicated means when it is recommended or necessary. Sodium bicarbonate is not a routine drug in cardiac arrest but is specifically indicated in cases of hyperkalemia, high potassium levels, with associated ECG changes, or in tricyclic antidepressant overdose, to help counteract metabolic acidosis. For example, if labs show a patient with significantly elevated potassium and their ECG shows widened QRS complexes, sodium bicarbonate can help stabilize the cardiac membrane. Remember that sodium bicarbonate has very specific uses and is not for every cardiac arrest. Question 9. What is the recommended dose of lidocaine for refractory ventricular fibrillation, VF, after initial doses of amiodarone have been given? A. 0.5 to 0.75 mg/kg/IO. B. 1 to 1.5 mg/kg/IO. C. 2 to 3 mg/kg/IO. D. 3 to 4.5 mg/kg/IO. Answer B. 1 to 1.5 mg/kg/IO. This question focuses on the appropriate dose of lidocaine, an antiarrhythmic drug, specifically when used for refractory ventricular fibrillation, VF, after amiodarone has already been administered. The phrase refractory ventricular fibrillation implies the continued need for antiarrhythmics, and after initial doses of amiodarone tells you lidocaine is a second-line option. If amiodarone is ineffective or contraindicated, lidocaine can be used with an initial dose of 1 to 1.5 mg per kilogram 4/IO for VF/private. This dose aims to suppress ventricular arrhythmias by affecting sodium channels in the heart. For example, if a patient remains in VF and amiodarone hasn't worked, administering lidocaine at this dose is the next step to try and stabilize the rhythm. Always keep in mind that lidocaine is an alternative antiarrhythmic if amiodarone isn't effective or suitable. Question 10. A patient presents with acute onset chest pain and ST segment elevation on their ECG. What is the appropriate initial action regarding oxygen administration? A. Administer oxygen routinely to all patients. B. Administer oxygen only if SpO2 is below 90%. C. Administer oxygen at 2 liters per minute via nasal cannula. D. Administer oxygen at 10 to 15 liters per minute via non-rebreather mask. Answer B. Administer oxygen only if SpO2 is below 90%. This question tests the current guidelines for oxygen administration in acute coronary syndromes, ACS, including ST segment elevation myocardial infarction, STEMI. The keywords acute onset chest pain and ST segment elevation point to a potential heart attack. Current ACLS guidelines recommend administering oxygen only if the patient is hypoxemic, SpO2 less than 90%, or if they are showing signs of respiratory distress, not routinely to all ACS patients. Giving oxygen when levels are already normal can actually cause harm by increasing coronary vascular resistance. For instance, if a patient's SpO2 is 96% and they have chest pain, you would not routinely give them oxygen. Remember to check oxygen saturation before giving oxygen. It's not a universal treatment for chest pain anymore. Question 11. What is the primary reason for administering epinephrine in cardiac arrest? A. To increase heart rate. B. To improve myocardial contractility. C. To cause vasoconstriction and improve coronary and cerebral perfusion. D. To dilate coronary arteries. Answer: C. To cause vasoconstriction and improve coronary and cerebral perfusion. This question asks about the main mechanism of action and benefit of epinephrine in the cardiac arrest setting. The keyword primary reason emphasizes the most critical effect. While epinephrine has various effects, its primary benefit in cardiac arrest is its alpha-adrenergic agonist effect, causing systemic vasoconstriction. This vasoconstriction increases aortic diastolic pressure and cerebral perfusion pressure, which are crucial for blood flow to the heart muscle and the brain during resuscitation. For example, when chest compressions are being performed, epinephrine helps to direct blood flow more effectively to the vital organs. Always remember that epinephrine's main role in cardiac arrest is to improve blood flow to the heart and brain through its powerful vasoconstrictive action. Question 12. Which medication is contraindicated in patients with a history of cocaine use presenting with chest pain? A. Aspirin. B. Nitroglycerin. C. Morphine. D. Beta blockers. Answer: D. Beta blockers. This question addresses a specific contraindication for a common cardiac medication in the context of cocaine use. The keyword cocaine use is the critical clue. Beta blockers are generally contraindicated in cocaine-induced chest pain or myocardial infarction because they can cause unopposed alpha-adrenergic stimulation, leading to worsening coronary vasoconstriction and hypertension, which can actually worsen the patient's condition. For instance, if a patient admits to recent cocaine use and has chest pain, administering a beta blocker could dangerously elevate their blood pressure and worsen heart ischemia. Always remember to avoid beta blockers in patients with suspected cocaine-related cardiac issues due to the risk of worsening vasospasm. Question 13. A patient in cardiac arrest has achieved ROSC but is profoundly hypotensive, BP 60/40 mmHg. After fluid boluses, what vasopressor would be indicated next? A. Amiodarone. B. Dopamine. C. Diltiazem. D. Adenosine. Answer: B. Dopamine. This question focuses on the pharmacological management of hypotension after return of spontaneous circulation, ROSC. The phrases achieved ROSC and profoundly hypotensive indicate a need for blood pressure support post-resuscitation. Dopamine is one of the recommended vasopressors to consider for hypotension after ROSC when fluids alone are insufficient, typically initiated at 5 to 10 mcg/kg per minute to increase blood pressure and improve cardiac output. For example, if a patient's blood pressure remains dangerously low after receiving 1 to 2 liters of 4 fluids, starting a dopamine infusion would be an appropriate next step to support their circulation. Remember that vasopressors like dopamine are used to maintain adequate blood pressure and perfusion to vital organs after the heart starts beating again. Question 14. What is the maximum total dose of atropine recommended for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 6 mg. Answer: C. 3 mg. This question tests knowledge of the dosage limits for atropine in symptomatic bradycardia. The keywords maximum total dose are crucial. The recommended dose of atropine is 0.5 mg for every 3 to 5 minutes, with a maximum total dose of 3 mg. Exceeding this dose is unlikely to provide further benefit and can potentially lead to anticholinergic side effects. For instance, if a patient receives 0.5 mg, then another 0.5 mg, and then another 0.5 mg, total 1.5 mg, they could receive up to an additional 1.5 mg before reaching the maximum limit. Always remember the 3 mg maximum dose for atropine to avoid administering more than is effective. Question 15. A patient with a suspected stroke arrives within the thrombolytic window. What drug is typically considered for fibrinolytic therapy? A. Heparin. B. Aspirin. C. Alteplase, TPA. D. Clopidogrel. Answer: C. Alteplase, TPA. This question asks about the specific drug used for fibrinolytic therapy in acute ischemic stroke, emphasizing the thrombolytic window. The keywords suspected stroke and thrombolytic window immediately point to the time-sensitive treatment for dissolving blood clots. Alteplase, recombinant tissue plasminogen activator, or TPA, is the only FDA-approved fibrinolytic drug for acute ischemic stroke, given intravenously to dissolve the clot causing the stroke. For example, if a patient with acute stroke symptoms arrives within 4.5 hours of symptom onset, they may be a candidate for alteplase administration to restore blood flow to the brain. Always remember that alteplase is the key medication for breaking up clots in eligible stroke patients. Question 16. What is the most common side effect expected immediately after administration of adenosine? A. Hypertension. B. Chest pain/flushing. C. Bradycardia. D. Seizures. Answer: B. Chest pain/flushing. This question explores the typical, transient side effects experienced after adenosine administration, which is used for stable SVT. The keyword immediately highlights the short-lived nature of these effects due to adenosine's very brief half-life. Patients commonly report a brief period of chest discomfort, flushing, dyspnea, shortness of breath, or lightheadedness immediately after adenosine is pushed, which resolves quickly as the drug is metabolized. For example, a patient might feel a sudden rush of warmth and pressure in their chest for a few seconds. Understand that these uncomfortable but temporary side effects are expected and signify the drug is working to temporarily stop the heart. Question 17. Which medication is the preferred pressor for septic shock that is unresponsive to fluid resuscitation? A. Dobutamine. B. Norepinephrine. C. Phenylephrine. D. Epinephrine. Answer: B. Norepinephrine. This question tests knowledge of vasopressor choice in a specific shock state, septic shock unresponsive to fluids. The keywords septic shock and unresponsive to fluid resuscitation are critical, indicating the need for a vasopressor. Norepinephrine, Levophed, is generally considered the first-line vasopressor for septic shock because it provides effective vasoconstriction to increase blood pressure with less increase in heart rate compared to some other pressors. For instance, if a patient remains hypotensive despite receiving appropriate fluid boluses for sepsis, starting a norepinephrine infusion would be the next step. Always remember that norepinephrine is often the initial go-to pressor for managing low blood pressure in septic shock. Question 18. What is the purpose of administering nitroglycerin to a patient with acute coronary syndrome? A. To increase blood pressure. B. To cause coronary vasoconstriction. C. To reduce cardiac preload and afterload, and dilate coronary arteries. D. To dissolve blood clots. Answer: C. To reduce cardiac preload and afterload, and dilate coronary arteries. This question asks about the therapeutic effects of nitroglycerin in the context of acute coronary syndrome, ACS, such as chest pain due to a heart attack. The keyword purpose focuses on its beneficial actions. Nitroglycerin primarily works by causing vasodilation, both in the coronary arteries, improving blood flow to the heart muscle, and systemically, which reduces preload, blood returning to the heart, and afterload, resistance the heart pumps against, thereby decreasing myocardial oxygen demand and relieving chest pain. For example, a patient with chest pain may feel relief after receiving sublingual nitroglycerin because it helps the heart work less hard and improves blood supply. Remember, nitroglycerin helps alleviate chest pain by widening blood vessels and easing the heart's workload. Question 19. A patient is in cardiac arrest due to suspected opioid overdose. In addition to standard ACLS, what medication should be considered? A. Flumazenol. B. Naloxone. C. Atropine. D. Glucose. Answer: B. Naloxone. This question introduces a specific cause of cardiac arrest, opioid overdose, which requires an additional, targeted medication. The keywords suspected opioid overdose are the critical clue. Naloxone is an opioid antagonist that can rapidly reverse opioid-induced respiratory depression and central nervous system depression, making it a crucial intervention in cardiac arrest suspected to be caused by opioids, alongside standard ACLS measures. For instance, if emergency responders find an unresponsive patient with pinpoint pupils and evidence of drug use, administering naloxone is a priority. Always remember to consider naloxone when an opioid overdose is suspected as the cause of collapse or cardiac arrest, as it can be life-saving. Question 20. What is the recommended infusion rate for lidocaine after a successful bolus for ventricular arrhythmias in a post-resuscitation setting? A. 0.5 to 1 mg/min. B. 1 to 2 mg/min. C. 2 to 4 mg/min. D. 4 to 6 mg/min. Answer: C. 2 to 4 mg/min. This question focuses on the maintenance infusion rate for lidocaine once a bolus has been given and ventricular arrhythmias are controlled in a post-resuscitation scenario. The phrase "after a successful bolus" and post-resuscitation setting indicates the need for ongoing therapy. After a successful bolus, lidocaine is typically infused at a rate of 1 to 4 mg per minute, or 2 to 4 mg/min depending on specific guidelines and patient condition, to maintain therapeutic levels and prevent recurrence of ventricular arrhythmias. For example, once a patient's ventricular tachycardia converts after a lidocaine bolus, starting a continuous infusion at 2 mg per minute would help prevent the rhythm from returning. Remember, continuous lidocaine infusions are used to keep ventricular arrhythmias from coming back after initial control. Question 21. Which medication is used in the ACLS algorithm to treat symptomatic bradycardia when atropine is ineffective? A. Amiodarone. B. Digoxin. C. Dopamine or epinephrine. D. Diltiazem. Answer: C. Dopamine or epinephrine. This question tests the second-line pharmacological management of symptomatic bradycardia when the initial drug, atropine, has failed. The phrase "atropine is ineffective" is the key indicator for moving to alternative treatments. If atropine doesn't improve the bradycardia and symptoms persist, either dopamine or epinephrine infusions are recommended. These drugs are vasoconstrictors and chronotropes, meaning they increase heart rate and blood pressure, acting as an interim measure while preparing for transcutaneous pacing. For example, if 3 mg of atropine has been given and the patient is still hypotensive with a slow heart rate, starting a dopamine drip would be appropriate. Remember that dopamine or epinephrine infusions are used to temporarily support heart rate and blood pressure when atropine alone isn't enough. Question 22. What is the immediate post-cardiac arrest management goal regarding mean arterial pressure, MAP? A. Maintain MAP greater than 65 mm of mercury. B. Maintain MAP greater than 80 mm of mercury. C. Maintain MAP greater than 90 mm of mercury. D. Maintain MAP greater than 100 mm of mercury. Answer A. Maintain MAP greater than 65 millimeters of mercury. This question assesses a critical hemodynamic goal in post-cardiac arrest care. The term immediate post-cardiac arrest management goal highlights the immediate physiological target after the heart starts beating again. The primary goal for blood pressure in the post-cardiac arrest phase is to maintain a mean arterial pressure, MAP, of at least 65 millimeters of mercury, which is generally considered sufficient to ensure adequate perfusion to vital organs like the brain and kidneys. For instance, if a patient's MAP is 55 millimeters of mercury after ROSC, interventions like fluids and vasopressors would be used to bring it above 65 millimeters of mercury. Remember that maintaining a MAP above 65 millimeters of mercury is crucial for supporting organ function after cardiac arrest. Question 23. What is the primary purpose of administering diltiazem in the ACLS algorithm? A. To treat narrow complex tachycardia unresponsive to adenosine. B. To treat wide complex tachycardia. C. To treat symptomatic bradycardia. D. To treat asystole. Answer A. To treat narrow complex tachycardia unresponsive to adenosine. This question asks about the main use of diltiazem, a calcium channel blocker, in the ACLS tachycardia algorithm. The keywords primary purpose are important. Diltiazem is often used to control the ventricular rate in stable, narrow complex tachycardias, such as atrial fibrillation or atrial flutter with a rapid ventricular response, especially if adenosine is ineffective or contraindicated. It slows conduction through the AV node. For example, if a patient has atrial fibrillation with a heart rate of 160 bpm and is stable, diltiazem can be used to bring the heart rate down. Remember that diltiazem is primarily used to slow down fast heart rhythms originating in the atria when adenosine is not appropriate or sufficient. Question 24. Which of the following is an indication for sodium bicarbonate administration in cardiac arrest? A. Routine use in all asystole arrests. B. Tricyclic antidepressant overdose. C. Suspected hypovolemia. D. Pulseless electrical activity, PEA, secondary to acute myocardial infarction. Answer B. Tricyclic antidepressant overdose. This question tests specific indications for sodium bicarbonate, highlighting that it's not a general-use drug in cardiac arrest. The keyword indication asks for a specific scenario where it's recommended. Sodium bicarbonate is not routinely used in cardiac arrest, however, it is specifically indicated in cases of known or suspected tricyclic antidepressant overdose, or for severe hyperkalemia, to help stabilize the cardiac membrane and counteract metabolic acidosis. For example, if a patient in cardiac arrest has a known history of ingesting a large amount of tricyclic antidepressants, sodium bicarbonate would be a targeted intervention. Remember that sodium bicarbonate has very specific uses, particularly for certain poisonings or severe electrolyte imbalances, not for every cardiac arrest. Question 25. What is the initial recommended dose of amiodarone for pulseless ventricular tachycardia, private, or ventricular fibrillation, VF, during cardiac arrest? A. 150 mg 4/IO. B. 300 mg 4/IO. C. 450 mg 4/IO. D. 1 mg per kilogram 4/IO. Answer B. 300 mg 4/IO. This question asks about the first dose of amiodarone in a cardiac arrest setting specifically for ventricular arrhythmias. The keywords initial recommended dose and pulseless ventricular tachycardia, private, or ventricular fibrillation, VF, point to the specific algorithm. The initial dose of amiodarone for VF/private that is unresponsive to defibrillation and epinephrine is 300 mg given 4/IO. This large loading dose helps to rapidly achieve therapeutic levels to stabilize the heart's electrical activity. For instance, if a patient continues in VF after a few shocks and epinephrine, administering 300 mg of amiodarone is the next step to try and convert the rhythm. Always remember that 300 mg is the first dose of amiodarone for cardiac arrest. Question 26. A patient with ST segment elevation myocardial infarction, STEMI, receives reperfusion therapy. What antiplatelet medication is routinely given in addition to aspirin? A. Warfarin. B. Clopidogrel. C. Rivaroxaban. D. Dabigatran. Answer B. Clopidogrel. This question tests knowledge of dual antiplatelet therapy in STEMI management after reperfusion. The phrase STEMI receives reperfusion therapy indicates the patient has undergone treatment to restore blood flow, and in addition to aspirin highlights the need for a second antiplatelet agent. Clopidogrel, or other P2Y12 inhibitors like ticagrelor or prasugrel, is routinely given in addition to aspirin after reperfusion therapy for STEMI to prevent further clot formation and stent thrombosis if percutaneous coronary intervention, PCI, is performed. For example, after a patient undergoes PCI for a heart attack, they will typically leave the hospital on both aspirin and clopidogrel. Remember that dual antiplatelet therapy with aspirin and a P2Y12 inhibitor like clopidogrel is standard after reperfusion for STEMI. Question 27. What is the primary use of magnesium sulfate in the ACLS algorithm, aside from torsades de pointes? A. Refractory VF/private in the presence of suspected hypomagnesemia. B. Routine use in all asystole arrests. C. Treatment for bradycardia. D. As a replacement for epinephrine. Answer A. Refractory VF/private in the presence of suspected hypomagnesemia. This question probes another specific indication for magnesium sulfate beyond its well-known use for torsades de pointes. The keyword aside from torsades de pointes directs you to its secondary use. Magnesium sulfate can also be considered for refractory, difficult to treat, ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, when hypomagnesemia, low magnesium levels, is known or suspected to be a contributing factor. For example, if a patient in cardiac arrest has a history of chronic alcoholism or malnutrition, magnesium might be considered if their VF/private is not responding to standard therapy. Remember, magnesium sulfate has a secondary role in refractory VF/private, especially when low magnesium levels are suspected. Question 28. What is the recommended intravenous fluid for initial resuscitation of hypovolemic shock in ACLS? A. Dextrose 5% in water, D5W. B. 0.45% sodium chloride, half normal saline. C. Lactated ringers or 0.9% sodium chloride, normal saline. D. Dextran. Answer C. Lactated ringers or 0.9% sodium chloride, normal saline. This question asks about the appropriate type of intravenous fluid for initial management of hypovolemic shock, which is shock due to severe fluid loss. The keyword hypovolemic shock indicates the underlying problem. Isotonic crystalloid solutions, such as lactated ringers or 0.9% sodium chloride, normal saline, are the recommended initial fluids for resuscitation in hypovolemic shock because they expand intravascular volume effectively without causing fluid shifts into cells. For example, if a patient has significant blood loss or dehydration causing low blood pressure, rapid infusion of normal saline would be the first step. Always remember that isotonic crystalloids are the go-to fluids for rapidly expanding circulating volume in hypovolemic shock. Question 29. A patient is experiencing stable wide complex tachycardia. If adenosine is ineffective, which antiarrhythmic medication would be considered next? A. Diltiazem. B. Metoprolol. C. Amiodarone. D. Verapamil. Answer: C. Amiodarone. This question tests the management of stable wide complex tachycardia that has not responded to initial therapy. The key phrases stable wide complex tachycardia and adenosine is ineffective are crucial, indicating that the rhythm is ventricular or a supraventricular rhythm with aberrancy, and a more potent antiarrhythmic is needed. Amiodarone is the preferred antiarrhythmic medication for stable wide complex tachycardia when adenosine is unsuccessful or if the rhythm is clearly ventricular in origin. It helps to stabilize the heart's electrical activity. For example, if a patient has a stable ventricular tachycardia that doesn't convert with adenosine, if tried, amiodarone is the next drug to consider. Remember that amiodarone is a strong choice for wide complex tachycardias when simpler options aren't effective. Question 30. Which medication is indicated for chest pain relief in acute coronary syndromes when nitroglycerin is ineffective? A. Naloxone. B. Morphine. C. Fentanyl. D. Ketamine. Answer: B. Morphine. This question addresses pain management in acute coronary syndromes, ACS, when initial treatments are not sufficient. The keywords chest pain relief, acute coronary syndromes, and nitroglycerin is ineffective point to the need for stronger analgesia. Morphine sulfate is indicated for chest pain relief in ACS if nitroglycerin does not adequately relieve the pain. It also has venodilating effects, which reduce cardiac preload and oxygen demand. For instance, if a patient continues to experience severe chest pain after multiple doses of nitroglycerin, administering morphine would be an appropriate next step. Always remember that morphine is used for ongoing chest pain in ACS when nitroglycerin isn't enough, but it should be used cautiously due to potential side effects like hypotension and respiratory depression. Question 31. What is the standard concentration for an epinephrine infusion when used as a vasopressor post-cardiac arrest? A. 1 mg in 1000 ml, 1 microgram per milliliter. B. 1 mg in 250 milliliters, 4 micrograms per milliliter. C. 1 mg in 100 milliliters, 10 micrograms per milliliter. D. 1 mg in 10 milliliters, 100 micrograms per milliliter. Answer: A. 1 mg in 1000 ml, 1 microgram per milliliter. This question focuses on the typical preparation of epinephrine for continuous infusion, particularly in a post-cardiac arrest setting where precise dosing is needed. The phrase standard concentration for an epinephrine infusion is key, indicating the need for a common, dilute preparation. Epinephrine infusions are typically prepared by mixing 1 mg of epinephrine in 1000 ml of fluid, e.g., normal saline, resulting in a concentration of 1 microgram per milliliter, which allows for titratable dosing, usually starting at 0.1 to 0.5 micrograms per kilogram per minute. For example, after ROSC, if a patient needs ongoing blood pressure support, an epinephrine drip would be started at a low mcg/min rate using this dilute preparation. Remember that for infusions, epinephrine is highly diluted to allow for gradual, titratable dosing to maintain blood pressure. Question 32. What is the initial drug of choice for a patient in unstable supraventricular tachycardia, SVT, with a pulse? A. Adenosine. B. Synchronized cardioversion. C. Diltiazem. D. amiodarone. Answer B. Synchronized cardioversion. This question distinguishes between stable and unstable tachycardias, focusing on the immediate intervention for an unstable rhythm. The key phrase unstable supraventricular tachycardia, SVT, with a pulse signifies that the patient has serious symptoms, like hypotension, altered mental status, or signs of shock, due to the rapid heart rate. For unstable tachycardias, synchronized cardioversion is the immediate treatment of choice, as pharmacologic agents may take too long or be ineffective in a crashing patient. For instance, if a patient with SVT becomes hypotensive and unresponsive, delivering synchronized cardioversion immediately is critical. Always remember that for any unstable tachycardia with a pulse, electrical cardioversion is the primary intervention. Question 33. What is the correct initial dose of dopamine infusion for symptomatic bradycardia unresponsive to atropine? A. 1 to 3 mcg/kg/min. B. 5 to 10 mcg/kg/min. C. 10 to 20 mcg/kg/min. D. 20 to 50 mcg/kg/min. Answer B. 5 to 10 mcg/kg/min. This question asks about the initial dosing of dopamine, used as an alternative to epinephrine for symptomatic bradycardia when atropine is ineffective. The keywords initial dose and symptomatic bradycardia unresponsive to atropine define the specific scenario. For symptomatic bradycardia unresponsive to atropine, the initial dopamine infusion rate is 5 to 10 micrograms per kilogram per minute, titrated to effect. This dose range primarily stimulates beta-1 adrenergic receptors, increasing heart rate and contractility, and alpha-adrenergic receptors, causing some vasoconstriction to raise blood pressure. For example, if a patient's heart rate remains dangerously slow with low blood pressure after atropine, starting a dopamine drip at 5 micrograms per kilogram per minute would be appropriate. Remember that dopamine is used at this specific dose range to support heart rate and blood pressure when atropine isn't enough. Question 34. A patient in cardiac arrest has achieved ROSC, but their heart rate is 45 bpm and they are hypotensive. Which vasopressor, in addition to fluids, would be appropriate to consider? A. Phenylephrine. B. Isoproterenol. C. Epinephrine infusion. D. Milrinone. Answer C. Epinephrine infusion. This question tests the management of post-cardiac arrest bradycardia and hypotension. The scenario achieved ROSC, but heart rate is 45 bpm and they are hypotensive describes a situation where both rate and blood pressure support are needed. Epinephrine infusion is an appropriate vasopressor to consider in this scenario because it can increase heart rate, chronotropic effect, and blood pressure, vasopressor effect, simultaneously, addressing both issues of bradycardia and hypotension post-ROSC. For example, if a patient has a slow heart rate and low blood pressure after cardiac arrest, an epinephrine infusion would help improve both parameters. Always remember that epinephrine infusion can be a valuable tool for supporting both heart rate and blood pressure after ROSC. Question 35. What is the typical effect of nitroglycerin on blood pressure when given for chest pain? A. Increases blood pressure. B. Decreases blood pressure. C. No significant effect on blood pressure. D. Fluctuation in blood pressure. Answer B. Decreases blood pressure. This question focuses on a common side effect of nitroglycerin. The keyword typical effect refers to its expected physiological action. Nitroglycerin causes vasodilation, widening of blood vessels, which reduces both preload, blood returning to the heart, and afterload, resistance the heart pumps against, leading to a decrease in systemic blood pressure. This is why it's contraindicated in patients with very low blood pressure or certain types of inferior myocardial infarction. For example, a patient might experience lightheadedness or dizziness due to the drop in blood pressure after taking nitroglycerin. Always remember that nitroglycerin lowers blood pressure, and this is why blood pressure must be monitored closely during administration. Question 36. Which drug is specifically indicated for severe symptomatic bradycardia or asystole in the setting of beta blocker or calcium channel blocker overdose? A. Atropine. B. Glucagon. C. Insulin. D. Sodium bicarbonate. Answer: B. Glucagon. This question asks about a specific antidote for severe bradycardia or asystole caused by overdose of certain cardiovascular medications. The phrase beta blocker or calcium channel blocker overdose is the critical clue. Glucagon is specifically indicated for severe bradycardia or asystole that is unresponsive to standard therapy, like atropine or pacing, in the context of beta blocker or calcium channel blocker overdose, as it can bypass blocked receptors and increase cyclic AMP, improving heart rate and contractility. For example, if a patient who overdosed on metoprolol has a very slow heart rate that doesn't improve with atropine, glucagon would be the next drug to consider. Remember that glucagon is a specific antidote for life-threatening bradycardia or asystole from beta blocker or calcium channel blocker overdose. Question 37. What is the recommended dose of alteplase, TPA, for acute ischemic stroke? A. 0.5 mg per kilogram 4. B. 0.9 mg per kilogram 4. C. 1.5 mg per kilogram 4. D. 50 mg 4 bolus. Answer: B. 0.9 mg per kilogram 4. This question specifically asks about the dose of alteplase, TPA, for acute ischemic stroke. The keywords recommended dose and acute ischemic stroke specify the precise application. The recommended dose of alteplase for acute ischemic stroke is 0.9 mg per kilogram, with a maximum total dose of 90 mg. Of this, 10% is given as an initial 4 bolus over 1 minute, and the remaining 90% is infused over 60 minutes. This precise dosing is crucial for maximizing effectiveness while minimizing bleeding risk. For example, if a 70 kg patient is eligible for alteplase, they would receive a total dose of 63 mg. Always remember the 0.9 mg per kilogram dose for alteplase in stroke, with 10% as a bolus and the rest as an infusion. Question 38. A patient is in cardiac arrest due to suspected hyperkalemia. In addition to calcium chloride, what other medication would be considered? A. Magnesium sulfate. B. Insulin with dextrose. C. Sodium polystyrene sulfonate. D. Activated charcoal. Answer: B. Insulin with dextrose. This question targets the specific pharmacological management of cardiac arrest caused by hyperkalemia, high potassium levels. The keywords suspected hyperkalemia and in addition to calcium chloride point to other treatments that lower potassium. In the setting of hyperkalemia-induced cardiac arrest, insulin with dextrose, glucose, is administered after calcium chloride. Calcium chloride helps to stabilize the cardiac membrane, while insulin facilitates the movement of potassium from the extracellular space into the cells, thus lowering serum potassium levels. For instance, if a patient with renal failure goes into cardiac arrest with peak T waves on ECG, insulin and dextrose would be given following calcium to shift potassium. Remember, insulin and dextrose are key for actually lowering potassium levels in hyperkalemia, while calcium chloride protects the heart. Question 39. What is the primary purpose of administering epinephrine in the setting of pulseless electrical activity, PEA, or asystole? A. To convert the rhythm to sinus. B. To increase myocardial contractility. C. To cause vasoconstriction and improve coronary and cerebral perfusion pressure. D. To dilate coronary arteries. Answer: C. To cause vasoconstriction and improve coronary and cerebral perfusion pressure. This question focuses on the primary benefit of epinephrine in non-shockable rhythms, PEA and asystole. The keyword primary purpose emphasizes its most critical effect. While epinephrine has various effects, its main role in PEA and asystole is its powerful alpha-adrenergic effect, which causes systemic vasoconstriction. This vasoconstriction increases aortic diastolic pressure and cerebral perfusion pressure, crucial for delivering blood flow to the heart and brain during chest compressions, increasing the chances of return of spontaneous circulation, ROSC. For example, even in asystole, epinephrine helps maximize the effectiveness of chest compressions by improving blood flow to vital organs. Always remember that epinephrine's main contribution in PEA and asystole is to improve blood flow to the heart and brain. Question 40. What is the recommended second dose of amiodarone for persistent VF/private during cardiac arrest after the initial 300 mg dose? A. 75 mg 4/IO. B. 150 mg 4/IO. C. 300 mg 4/IO. D. 450 mg 4/IO. Answer: B. 150 mg 4/IO. This question asks about the subsequent dose of amiodarone for persistent ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, in cardiac arrest. The keywords second dose and after the initial 300 mg dose are key. If VF/private persists after the initial 300 mg dose of amiodarone, a second dose of 150 mg 4/IO may be given. This sequential dosing aims to provide additional antiarrhythmic effect to achieve rhythm conversion. For instance, if a patient remains in VF after the first 300 mg of amiodarone, administering another 150 mg is the next step in the algorithm. Remember that the second dose of amiodarone is 150 mg, half of the initial dose. Question 41. Which medication is recommended for a patient with acute coronary syndrome and persistent chest pain despite maximal medical therapy, but who is not a candidate for reperfusion? A. Fibrinolytic agents. B. Heparin. C. Aspirin. D. Glycoprotein IIB/3A inhibitors. Answer: B. Heparin. This question addresses the role of anticoagulation in acute coronary syndromes, specifically for patients not receiving reperfusion. The key phrases persistent chest pain, acute coronary syndrome, and not a candidate for reperfusion indicate the need for medical management to prevent further clotting. Anticoagulants like unfractionated heparin or low molecular weight heparin are recommended for patients with acute coronary syndrome, especially those with STEMI, non-ST elevation myocardial infarction, or unstable angina, who are not undergoing immediate reperfusion, to prevent further thrombus formation. For example, if a patient has chest pain and elevated troponins but no STEMI, heparin would be part of their medical management. Remember that anticoagulants like heparin are crucial for preventing blood clots from worsening in ACS, especially if reperfusion isn't happening immediately. Question 42. What is the appropriate interval for repeat doses of epinephrine during cardiac arrest? A. Every 1 to 2 minutes. B. Every 3 to 5 minutes. C. every 5 to 7 minutes. D. Every 10 minutes. Answer B. Every 3 to 5 minutes. This question asks about the standard frequency of epinephrine administration during cardiac arrest. The keywords appropriate interval and during cardiac arrest are crucial. Epinephrine is administered at a dose of 1 mg 4/IO every 3 to 5 minutes throughout the cardiac arrest resuscitation attempt, regardless of the underlying rhythm. This consistent timing helps maintain the drug's beneficial effects, such as vasoconstriction, to support vital organ perfusion during chest compressions. For example, after the first dose of epinephrine, the next dose should be prepared and given approximately 3 to 5 minutes later. Always remember the 3 to 5 minute interval for epinephrine dosing in cardiac arrest. Question 43. A patient has a suspected tricyclic antidepressant, TCA, overdose and develops a wide QRS complex tachycardia. What medication should be considered? A. Magnesium sulfate. B. Sodium bicarbonate. C. Calcium chloride. D. Atropine. Answer B. Sodium bicarbonate. This question presents a specific toxicology scenario leading to a cardiac arrhythmia. The key phrase, tricyclic antidepressant, TCA, overdose is the critical clue, as TCAs can cause cardiotoxicity. Sodium bicarbonate is specifically indicated for widening of the QRS complex and arrhythmias associated with tricyclic antidepressant overdose, as it helps to overcome the sodium channel blockade caused by these drugs. For example, if a patient with a known TCA overdose suddenly develops a wide QRS complex on their ECG, administering sodium bicarbonate is a key intervention to stabilize the heart. Remember that sodium bicarbonate is a life-saving antidote for the cardiac effects of tricyclic antidepressant overdose. Question 44. In the management of stable narrow complex tachycardia, what is the initial drug to be administered if vagal maneuvers are unsuccessful? A. Verapamil. B. Diltiazem. C. Adenosine. D. Metoprolol. Answer C. Adenosine. This question focuses on the first-line drug for stable narrow complex tachycardia, after non-pharmacological interventions. The keywords stable narrow complex tachycardia and vagal maneuvers are unsuccessful are key indicators for adenosine's role. Adenosine is the first-line pharmacological agent for stable narrow complex SVT because it temporarily blocks conduction through the AV node, which often terminates the re-entry circuit causing the tachycardia. For instance, if a patient has a stable SVT at 180 bpm and Valsalva maneuver doesn't work, adenosine would be given next. Always remember that adenosine is the drug of choice for stable narrow complex SVT after trying vagal maneuvers. Question 45. What is the recommended dose of morphine for chest pain in acute coronary syndromes? A. 1 to 2 mg for every 5 to 15 minutes. B. 2 to 4 mg for every 5 to 15 minutes. C. 5 to 10 mg for every 5 to 15 minutes. D. 10 to 20 mg for every 5 to 15 minutes. Answer B. 2 to 4 mg for every 5 to 15 minutes. This question asks about the appropriate dosing of morphine for chest pain relief in acute coronary syndromes. The keywords recommended dose and chest pain in acute coronary syndromes define the context. Morphine sulfate is typically administered in small, titrated 4 doses of 2 to 4 mg every 5 to 15 minutes as needed for ongoing chest pain that is not relieved by nitroglycerin. This approach helps to balance pain relief with potential side effects like hypotension and respiratory depression. For example, If a patient has persistent severe chest pain, a 2 mg 4 dose of morphine would be given, and repeated if necessary, while monitoring their vital signs. Remember to titrate morphine carefully in small doses to manage pain and avoid excessive side effects. Question 46. For a patient in cardiac arrest with asystole, what is the primary drug to be administered? A. Atropine. B. Epinephrine. C. Vasopressin. D. Amiodarone. Answer: B. Epinephrine. This question is about the primary pharmacological intervention for asystole, a non-shockable cardiac arrest rhythm. The keywords cardiac arrest and asystole point directly to the standard medication. Epinephrine is the primary drug given for asystole and PEA, with a dose of 1 mg 4/IO every 3 to 5 minutes. While it won't directly create a rhythm from asystole, its vasoconstrictive effects improve coronary and cerebral perfusion during chest compressions, increasing the chance of return of spontaneous circulation, ROSC. For example, if a patient is found in asystole, after confirming the rhythm, chest compressions and epinephrine should be initiated. Always remember that epinephrine is the cornerstone drug for non-shockable rhythms like asystole and PEA. Question 47. What is the primary side effect to monitor for after rapid 4 push of adenosine? A. Bradycardia. B. Hypertension. C. Prolonged QTc interval. D. Allergic reaction. Answer: A. Bradycardia. This question asks about the most significant and expected cardiac effect after a rapid push of adenosine. The keywords primary side effect and rapid 4 push of adenosine are crucial. Adenosine works by briefly blocking the AV node, which can cause a very short period of asystole, a flat line on the ECG, or severe bradycardia before the heart's normal rhythm typically resumes. This is a therapeutic effect, though it can be unsettling to witness. For instance, after adenosine, the heart monitor might show a brief pause of a few seconds, which is a normal response before the SVT terminates. Remember that the temporary slowing or stopping of the heart is an expected, although transient, effect of adenosine as it works to reset the rhythm. Question 48. A patient has a suspected stroke, but fibrinolytic therapy, e.g., alteplase, is contraindicated. What antiplatelet medication should be administered instead? A. Warfarin. B. Heparin. C. Aspirin. D. Dabigatran. Answer: C. Aspirin. This question addresses stroke management when a patient is not eligible for clot-dissolving therapy. The keywords suspected stroke and fibrinolytic therapy contraindicated are crucial, indicating the need for an alternative antithrombotic. For patients with acute ischemic stroke who are not candidates for fibrinolytic therapy, aspirin, usually 160 to 325 mg orally, should be administered as soon as possible, ideally within 24 to 48 hours of symptom onset, to prevent early recurrent ischemic stroke. For example, if a patient presents with stroke symptoms but has a contraindication like recent surgery that prevents alteplase, they would be given aspirin. Remember that aspirin is the immediate antiplatelet for stroke patients who cannot receive clot-busting medications. Question 49. What is the recommended infusion dose range for norepinephrine, Levophed, in profound hypotension after ROSC? A. 0.01 to 0.05 mcg/kg/min. B. 0.1 to 0.5 mcg/kg/min. C. 1 to 5 mcg/kg/min. D. 5 to 10 mcg/kg/min. Answer: B. 0.1 to 0.5 mcg/kg/min. This question focuses on the appropriate dosing range for norepinephrine when used as a vasopressor post-cardiac arrest to manage low blood pressure. The keywords infusion dose range, norepinephrine, levofed, and profound hypotension after ROSC are key. Norepinephrine is a potent vasopressor, and its typical initial infusion dose for profound hypotension after ROSC is 0.1 to 0.5 micrograms per kilogram per minute, titrated to maintain a target blood pressure, e.g., MAP greater than 65 mm of mercury. For example, if a patient's blood pressure remains very low after fluids, a norepinephrine infusion would be started at a low dose and gradually increased until the target MAP is achieved. Always remember that norepinephrine is a powerful vasopressor, and it's titrated carefully in very small mcg/kg/min doses to manage blood pressure. Question 50. A patient experiences chest pain and ST segment elevation. They are allergic to aspirin. What antiplatelet medication could be considered as an alternative for initial management? A. Clopidogrel. B. Warfarin. C. Heparin. D. Dabigatran. Answer: A. Clopidogrel. This question addresses a specific scenario in acute coronary syndrome where a common medication, aspirin, is contraindicated due to allergy. The keywords ST segment elevation, allergic to aspirin, and antiplatelet medication highlight the need for an alternative antiplatelet. If a patient with acute coronary syndrome, ACS, has a true aspirin allergy, AP2Y12 inhibitor such as clopidogrel can be considered as an alternative antiplatelet therapy for initial management to prevent further clot formation. For instance, if a patient presents with STEMI symptoms and reports a severe aspirin allergy, clopidogrel would be the appropriate antiplatelet to administer. Always remember that for aspirin-allergic ACS patients, AP2Y12 inhibitor like clopidogrel is the next best choice for antiplatelet therapy.